Welcome to the Deep Dive. This is where we take the material, you send us notes, articles, whatever you've got, and, well, we dive deep to pull out the really essential stuff.
Exactly. We sort through it all with you, aiming to make complex information clear and memorable. High yield, basically.
And today, we're tackling something specific based on revision notes you provided. We're looking at temporal arteritis, which is also called giant cell arteritis, or GCA.
Right. So our mission here is to take these notes and really unpack them, cover all the key points from definition to complications, making it hopefully really useful for understanding and revision.
Okay, let's get started. Definition first. What exactly is temporal arteritis, according to these notes?
So the notes define it as a chronic inflammatory condition. It affects arteries in the head, specifically those temporal arteries on the sides of your head.
Inflammation.
Yeah.
So the notes mention thickening and narrowing of the arteries. Is that the main issue?
That's pretty much it. The inflammation makes the artery wall swell up, thicken, and that narrows the space inside, where the blood flows.
And it's got other names, too.
Yeah, the notes list giant cell arteritis, GCA, and cranial arteritis as synonyms. You'll see them used interchangeably.
Okay, and right away, these notes flag it as medical emergency in ophthalmology.
That sounds pretty serious. Why the urgency?
It's all about the eyes. The risk of vision loss is really high. These notes are very clear. If you don't catch it and treat it fast, that reduced blood flow can permanently damage the optic nerve.
Leading to blindness.
Potentially, yes.
Oh.
Irreversible blindness. That's why spotting it early and starting treatment, well, it's absolutely critical.
Okay, so a serious inflammatory condition affecting head arteries, major risk to vision. What actually causes it? What do the notes say about the etiology?
Well, frustratingly, the notes say the exact cause isn't known. Seems to be a combination of things like a genetic predisposition, maybe, and the immune system going a bit haywire.
Immune system attacking the arteries.
Basically, yeah. Your own immune cells mistakenly target the artery walls, kicking off that inflammation. And there's a really strong connection mentioned here with another condition, polymyalgia rheumatica, PMR.
Oh, absolutely. This link is crucial, especially for revision. The notes give some striking figures. Something like 40 to 60% of people with temporal arteritis also have PMR.
Wow.
Yeah. And the other way around, about 16 to 21% of people diagnosed with PMR turn out to have temporal arteritis too.
So they likely share some common ground, maybe.
It certainly suggests that. Shared genetic factors, similar inflammatory pathways, probably. The key takeaway from the notes here is, if you have a patient with PMR and they develop new symptoms like fever, weight loss, or their PMR just isn't getting better with usual treatment.
You have to think GCA.
Exactly.
Yeah.
You absolutely have to consider temporal arteritis. It's a major red flag. The notes also briefly mention a possible increased risk of peripheral arterial disease later on, too. Something to bear in mind.
Okay, so who's most likely to develop this? What are the key risk factors in these notes?
Age is the big one. It's almost exclusively seen in people over 50. The average age is around 70, actually.
And gender.
Women are more affected. The notes say about 2.5 times higher risk compared to men.
And genetics keeps coming up.
Yes, it's definitely a factor. The notes mention links to specific gene variations like HLA-DRB1. And for Caucasians, one specific type, HLA-BR104, seems linked to higher risk and maybe even more complications like vision loss, possibly even resistance to steroid treatment.
So older age, female sex, and that specific genetic background are the main things pointing towards higher risk.
Pretty much, yeah. Those are the key demographics.
Right. Let's talk pathophysiology. How does this inflammation actually cause problems inside the artery? What's the mechanism described?
The core process is what's called granulomatous inflammation in the artery wall. Granulomatous just means a specific pattern of chronic inflammation with cells clumping together.
That's right.
And this process makes the artery wall thicken up and crucially narrow.
Like a pipe getting blocked from the inside out.
Exactly like that. The lumen, the channel inside, gets smaller and smaller. Sometimes it can even get completely blocked, which is called occlusion.
And if the blood can't get through?
That's ischemia. The tissues that artery supplies don't get enough oxygen or nutrients. And that lack of blood supply causes damage, which leads to the symptoms, especially in really sensitive places like the eyes or the brain.
Given the symptoms can overlap with other things, headache, pain, I imagine there's a list of other conditions to rule out. The differential diagnosis.
Oh, definitely. The notes list quite a few things you need to think about. Other kinds of vasculitis, for instance, different conditions causing blood vessel inflammation.
Right.
Also infections like meningitis or Lyme disease. even malignancies. And then common things like migraine, tension headaches, or trigeminal neuralgia can sometimes mimic the symptoms.
The notes list a few specific conditions, too. Takayasu's polyarteritis nodosa.
Yes, exactly. Takayasu's arteritis, that's another large vessel vasculitis, but usually in younger people. Polyarteritis nodosa, polymyositis, that last one causes muscle pain, so it can overlap with the PMR picture, but the underlying cause is different.
Right. It really highlights that the symptoms alone aren't specific, doesn't it? You need those risk factors and then proper investigation, because it could be many things.
Absolutely. You need a high index of suspicion, but you have to actively rule out these other possibilities.
How common is GCA? And where do you see it most often? What do the epidemiology notes say?
In the UK, the notes state it's around 18 cases per 100,000 people per year. Interestingly, it's higher in Northern European countries, maybe 20 per 100,000, and in people with that ancestry. Less common in other groups.
And it confirms the age and sex thing again.
Yes, definitely reinforces it. Typically over 50, I mean age 70, incidence goes up the older you get, especially over 70. And that 2.5 times higher risk for women is repeated here too.
And the genetics.
That HLA-BR104 link in Caucasians is mentioned again in the epidemiology section too, just hammering home its significance.
Okay, let's really try and nail down the clinical presentation. What signs and symptoms are we looking for according to these notes?
Well, the absolute classic is a severe headache, often around the temples, described as sharp or burning sometimes. Scalp tenderness is another big one. Just touching the scalp or hair can be really painful.
And the jaw pain. Jaw claudication?
Yes, that's highly suggestive. Pain in the jaw muscles when chewing, which eases off when you stop. That's jaw claudication. And then visual problems are a major red flag.
Like what kind of visual problems?
Blurred vision, double vision diplopia, or really critically, sudden vision loss. It could be temporary or, sadly, permanent in one or both eyes. Plus, people often feel generally unwell, fatigue, weight loss, maybe a fever.
Does it always come on suddenly?
The notes say it can be sudden or it can creep up more gradually. Sometimes the scalp tenderness even starts before the headache. And just to reiterate that statistic, vision loss happens in about 30% of people.
Wow.
And it's permanent in 10-15%. That really underscores the need for speed.
The notes also have a really detailed list of diagnostic indicators, specifically for people over 50. These must be the high-yield things to spot.
Absolutely. If someone's over 50, you're looking for any new type of headache, especially temporal. Checking the temporal artery itself. Is it tender, thickened, nodular? Maybe the pulse is weaker.
Okay.
Any visual symptoms at all? Scalp tenderness, that jaw claudication we mentioned. Systemic symptoms like fever, fatigue, weight loss. Any features of PMR, the muscle pain and stiffness.
It goes on. Neurological signs, too.
Yeah, things like weakness, maybe signs of a TIA or stroke, problems with eye movements or facial sensation from cranial nerve issues. Less commonly, maybe a cough or a sore throat, or even signs suggesting larger arteries are involved, like different blood pressures in the arms, limb pain when walking, chest or back pain.
That's a really wide range of possibilities.
Yeah.
Makes sense why the notes say consider other diagnoses if things seem unusual.
Exactly. It takes careful assessment and keeping possibilities open.
So if you suspect GCA, how do you actually confirm it? What about investigations?
Blood tests are usually the first step. The key things these notes point to are raised inflammatory markers, ESR and CRP. They're usually very high in GCA.
Okay, ESR and CRP up. Anything else in the blood work?
You might see a mild type of anemia, often high platelets, that's thrombocytosis. Usually, things like autoantibodies and complement levels are normal, which helps rule out other autoimmune stuff. Muscle enzymes are typically normal too, again helping differentiate. And sometimes liver function tests, especially alkaline phosphatase, can be a bit elevated.
But what's the definitive test? The gold standard.
That's the temporal artery biopsy. The notes describe taking a small piece of the temporal artery, usually from the side where the symptoms are worse, and looking at it under the microscope.
And what are they looking for?
For that characteristic granulomatous inflammation and maybe those giant cells that give it its name.
Is imaging used as well?
Yes, increasingly so. Color duplex ultrasound of the temporal arteries is common. It looks for things like a halo sign indicating wall thickening or blockages. The notes give sensitivity around 78%, specificity 79%.
The BT scans.
PET-CT can also be useful, especially if you suspect inflammation in larger arteries elsewhere. Notes say sensitivity 71%, specificity 91%. They're helpful tools, but the biopsy is still often considered crucial for a definite diagnosis, particularly if the imaging isn't clear-cut.
Right, so diagnosis confirmed or highly suspected. What's the management plan according to these notes?
The absolute cornerstone, stressed repeatedly, is high-dose corticosteroids, usually prednisolone. The goal isn't just symptoms, it's preventing those irreversible complications.
Especially the vision loss.
Exactly, especially the vision loss.
And it needs to happen fast.
Urgently. The notes emphasize urgent specialist referral. And treatment with high-dose steroids should start immediately as soon as you strongly suspect GCA, particularly if there's any visual threat. Don't wait for the biopsy results in that situation.
What kind of doses are we talking about?
The notes give specific starting points: 40 milligrams of prednisolone daily if there are no ischemic symptoms like jaw claudication or vision issues. It jumps to 60 milligrams daily if there is claudication.
And if there are visual symptoms?
That's an emergency. Hospital admission for IV methylprednisolone high dose straight into the vein for the fastest effect.
And this isn't just a short course of treatment.
No, definitely not. It's long term. The notes describe a very gradual taper of the steroid dose over months, even years, guided by how the symptoms are doing and whether the inflammatory markers like ESR and CRP are coming down.
They outline a typical taper.
Yeah, something like reducing by 10 milligram steps every couple of weeks down to 20 milligrams daily, then slower reductions, maybe 2.5 milligram steps after that. It takes time.
And what if symptoms flare up during the taper?
That's common, apparently. The notes say flare-ups and relapses respond well to just increasing the steroid dose again temporarily.
But these high doses for a long time. Side effects must be a big issue.
A huge issue. The notes are pretty blunt, saying significant side effects, glucocorticoid toxicity, happen in up to 80% of patients. Things like osteoporosis are a major risk, so bone protection treatment is essential for anyone on long-term steroids.
Are there other drugs used to help maybe reduce the steroid need?
Yes, thankfully. To help lower the steroid dose and minimize those side effects, other immunosuppressants might be added. The notes specifically mention methotrexate, or tocilizumab.
Tocilizumab.
Yeah, it's an antibody drug that targets a key inflammatory signal called IL-6. The notes highlight it as being really effective as a glucocorticoid-sparing agent. It can even help achieve remission without steroids in a good number of patients, the notes quote, 56%. So that's a really important option, especially if the steroid risks are high.
Okay, so putting it all together, what's the general outlook, the prognosis for someone with GCA based on these notes?
Well, if it's caught and treated properly, the prognosis for controlling the inflammation and improving most symptoms is generally pretty good. People usually respond well to the steroids initially.
But relapses can happen.
Yes, the notes warn that relapses are frequent. Up to 50% of people might experience one, often when they're trying to reduce the steroid dose.
And the vision aspect again.
That's the key point on prognosis, really. If visual damage occurs before treatment starts, it's often permanent. The notes say 15–20% end up with some degree of permanent vision loss. So symptoms get better, but that damage can't usually be undone.
And how long does treatment usually go on for?
Typically 1 to 2 years on steroids, according to the notes, sometimes even longer on a low maintenance dose. But the good news is overall lifespan seems pretty similar to the general population, though there is that increased long-term risk of problems with large arteries, like aneurysms, which leads us right into complications. What are the big dangers if GCA isn't treated or treated late?
We've hit vision loss hard.
Because it's the most common and feared one, yeah. Permanent blindness from the ophthalmic artery getting blocked. But the notes list other serious things too, driven by the vasculitis itself.
Like what?
Cardiovascular issues, aortic aneurysms where the main artery bulges, and aortic dissection, which is a tear in its wall. Both are life-threatening emergencies. The inflammation can affect other arteries too, and there's a higher risk of stroke or TIAs.
And then there are the side effects from the treatment we just discussed.
Exactly. The notes clearly list the risks from long-term steroids. Osteoporosis leading to fractures, muscle weakness, mood changes, high blood pressure, diabetes, high cholesterol. Managing the disease means managing the treatment side effects too.
Wow. Okay. We've really unpacked quite a bit there. From the basic definition and why it's urgent, through who gets it, how it works, what else it might be, the symptoms, tests, treatment, outlook, and those potential complications.
Yeah, hopefully breaking down these notes like this helps you, our listener, see the connections and remember the high-yield points. Recognizing the key features, understanding that urgency around vision, it's just so critical with GCA.
It really is. Getting those details organized makes a huge difference to understanding the bigger picture.
And thinking about that treatment, the corticosteroids, They work, but the toxicity is a real issue in so many patients, as the notes point out. It makes you wonder, doesn't it, given we still don't know the exact trigger for GCA? Well, how might future research into that root cause lead us to treatments that are, just as effective but maybe less toxic? More targeted therapies, perhaps. Something to think about.
That's a really interesting point to end on, the potential for future therapies based on understanding the why. Thank you for bringing in these notes for us to dive into. We really hope this structured discussion of temporal arteritis has been helpful for your understanding and revision.
Absolutely. Synthesizing information like this is key.
Couldn't agree more. And if you're looking for more resources to help with revision, do check out pathomsra.com and freemsra.com. Thanks again for joining us on this deep dive.
See you next time.